Yeah.
All right, everyone, we'll go ahead and get started with our next speaker. And I'll let Dr. Block introduce Dr. Bowie.
Okay, I'm very pleased to introduce Dr. Bowie today. She is a breast surgical oncologist at Mayo Clinic. She is currently division chair of the Breast and Melanoma Surgical Oncology and the Breast Cancer Disease Group chair at Mayo Clinic. And her practice philosophy focuses on patient-centered care. And her attention is primarily at trying to focus on safely de-escalating breast cancer treatment and individualizing care. Dr. Bowie?
Thank you so much for allowing me to join you today, and thanks. Hopefully the virtual platform is working pretty well and you can hear me well. I'm going to try and share my screen here. It might make the other slide come down. So for today's talk, I wanted to talk a little bit about my passion in de-escalation. The talk title is Surgical Updates. And so it's going to be kind of an overview of multiple things that have been advancing in the surgical fields. So you can see my disclosures on the screen. None of these really relate to what I'll be talking about today. So for the first part of this talk, I wanted to present the data that was just presented at San Antonio Breast Cancer Conference just last month, looking at breast conserving therapy for patients who have multiple ipsilateral breast cancer, because that's pretty hot off the press. And then for the second part of my talk, I wanted to talk about de-escalating axillary surgery. And we'll talk about areas where we can both either avoid axillary surgery altogether, and then some areas where we can minimize the extent of what we have to do surgically in the axilla. So in terms of breast conservation for patients with multiple ipsilateral breast cancer, this was the results of the prospective ACOSOG Z11102 clinical trial. This was run as part of the Alliance for Clinical Trials in Oncology. And historically, we've seen an increase in the diagnosis of multiple ipsilateral breast cancer, and that's also due to improved screening, as well as improved diagnostic imaging, and increasing use of breast MRI for patients with newly diagnosed breast cancer. And historically, the retrospective studies had shown relatively high rates of local regional recurrence in patients with multiple ipsilateral breast cancer who were treated with breast-conserving therapy. And this led many surgeons to essentially recommend mastectomy for most of these patients. There were some more recent studies in the late 1900s that did show better local control with the use of breast conservation in this setting. And this was because we've seen advances in breast imaging techniques, in our pathological assessment of margins, in our systemic therapy, as well as our targeted radiation therapy. And so all of that was really the premise to designing the Z11102 clinical trial. And this was a single-arm prospective phase 2 trial to look at the role of breast conservation in women who were diagnosed with 2 or 3 lesions within one breast. We limited it to patients that were over the age of 40 and had 2 or 3 foci of disease. At least one of the sites of disease had to be invasive disease, and the other site could be either invasive or DCIS. There had to be at least 2 centimeters of normal tissue between the lesions. So we were really trying to avoid recruiting patients that just had a lesion and a close-by satellite. This was truly 2 separate lesions within the breast. And the extent of disease could not occupy more than half the breast or more than 2 quadrants. And patients could be clinically node negative or have N1 disease. We excluded those that had disease that was more than 5 centimeters in size, patients with bilateral disease, those that had a known history of ipsilateral breast cancer, those that had a known genetic mutation, although not all patients were tested, and then those patients treated with neoadjuvant therapy. So patients were registered. If they were interested in breast conservation, they were enrolled on the study. They underwent their breast conserving surgery, which could be either through 2-site lumpectomy or a single-site incision excising both areas of disease. Nodal staging was required by the protocol. Patients were not allowed to receive neoadjuvant therapy, so this was all upfront surgery. And then they could have adjuvant chemotherapy at the discretion of their treating medical oncology team. The radiation was protocol driven, so it was whole breast radiation with a boost to each of the lumpectomy cavity. Management of the regional nodes was at the discretion of the radiation oncologist. And then, as per standard, patients were recommended endocrine therapy for ER or PR positive tumors. And then these patients were followed for 5 years, every 6 months, and we were pleased to report the 5-year outcome on the study. The primary endpoint was to look at local recurrence rate in patients with multiple ipsilateral breast cancer, and the protocol defined that an acceptable 5-year local recurrence rate would be less than 8%. We've published a couple of previous outcomes from this study prior to the 5-year follow-up that I think are really interesting just to pause and mention. One of these was the rate of conversion to mastectomy due to positive margin. So we had 14 patients, or 7%, that did convert to mastectomy in this cohort. Obviously, they're not included in this primary analysis at this point. And the vast majority of patients, 67%, actually achieved a margin negative excision in a single operation and didn't require a second operation. We did breast Q for outcomes data. So patient-reported outcome was good or excellent in 70% of patients at 2 years, and we plan to follow that up now with the 5-year data here this year. And then overall, there was a lot of concern about how people would be able to adhere to the protocol-directed radiation, but we had very strong adherence to the protocol-directed radiation, which did a boost to each of the lumpectomy sites. And although it had a higher association with acute dermatitis, there was no worsening of overall cosmesis. So overall, patients on this trial did pretty good. So now as we look at the primary endpoint of the 270 patients enrolled, we had 204 that were eligible for evaluation of the primary endpoint. We can see here the cohort that was enrolled was predominantly patients with 2 foci of disease. Clinical T1 disease was 60% of the patients, and 40% had T2 disease. Vast majority had ER positive, HER2 negative disease. About 78% of the population was clinically and pathologically node negative, and 29% of this patient population received adjuvant chemotherapy. So 6 of the 204 patients over the 5 years have developed a local recurrence. 4 of these are within the ipsilateral breast. 1 is in the ipsilateral skin, and 1 is within the ipsilateral chest wall. And so this gives an estimated 5-year local recurrence rate of 3.1%. And we can see that 95% confidence interval range between 1.3 and 6.4. So this remains well below that 8% clinically significant threshold that was set by the protocol. In addition to the 6 local recurrences, it's important to note that we had no patients that developed a regional recurrence in the ipsilateral axillary nodes. We did have 6 patients that developed a contralateral breast cancer and 4 patients that developed distant disease. There were 3 patients who developed new non-breast cancer primaries, and of the 8 patients that died in our 5 years of follow-up, the vast majority were not related to breast cancer, with only 1 breast cancer-related death. We try to look at variables that were associated with local recurrence, and I'll be honest with you, it's hard to look at that when you only have 6 local recurrence events. But we did not see that 2 versus 3 foci was significantly different. It's important to note, though, that the number of patients enrolled in the study that had 3 separate areas of disease was very low, with only 7 patients. T category and N category, while the local recurrence rate was numerically higher with larger tumors and nodal involvement, this was not statistically significant. Same with margins. Closer margin had a numerically higher risk, but again, not statistically higher risk of local recurrence, and tumor histology did not impact local recurrence. When we dig down and look at tumor biology, as I mentioned, the vast majority of patients enrolled were ER positive and HER2 negative, which is, I think, really what one would expect in this day and age, when many patients with HER2 positive and triple negative disease are being treated with neoadjuvant chemotherapy. The local recurrence rate in the ER positive, HER2 negative group was 2.6%. So far, none of the HER2 positive patients have had a local recurrence, and there's been one local recurrence in the triple negative group, but this was the smallest group. So the estimated 5-year risk of local recurrence, 10%, but again, small numbers here. One of the interesting things that we did in 2015, we amended the protocol to allow enrollment of patients who had not had a preoperative breast MRI. And this was really not a planned analysis, but we did have a look at the local recurrence rates in those patients that had had a preoperative MRI and those that had not. And strikingly, the vast majority of patients did have a preoperative MRI, but in the 15 patients that did not have an MRI, 3 of the local recurrences occurred in that group. So the 5-year local recurrence rate was significantly higher at 23% in those without a breast MRI than the 2% in the patients with a breast MRI. So I think this is very interesting and hypothesis generating data. Another factor we identified, and again, I don't think this will be very surprising to this audience, is that those patients that did not have adjuvant endocrine therapy had a higher local recurrence rate than those patients that did have endocrine therapy. So this analysis is limited to those patients that had at least one lesion that was estrogen receptor positive. With endocrine therapy, local recurrence rate around 2%, without it around 12%. And that was statistically significant. So it's a single arm study. It's a small study. Some of the subsets as we dive into it, as we mentioned, such as those that didn't have a preoperative MRI or those with HER2 positive or triple negative disease, and those patients that have 3 areas of disease are all small subsets. So it's difficult to generalize too much based on these subsets. And given that the vast majority of our patients were ER positive, one can argue that the 5-year follow-up on this protocol is short, but the protocol was written for a 5-year follow-up and the study is now closed. Overall, conclusions from the 11102 study, I think, show that for patients who have multiple ipsilateral breast cancer, breast conserving surgery followed with adjuvant radiation therapy, including boost to the lumpectomy site, has a low local recurrence rate of around 3% at 5 years. The majority of the patients enrolled in this study were postmenopausal with ER positive HER2 negative disease, had just 2 sites of disease, and about 70% were node negative. The 2 factors that we identified that potentially impact local recurrence is the use of a preoperative MRI. And while I don't necessarily think that all patients need a preoperative MRI, I think if you have a patient that you know already has 2 foci of disease and that patient is interested in breast conserving surgery, then I think that would be a reasonable candidate to consider an MRI before proceeding with breast conservation. And then, as is standard with unifocal disease, for patients with multifocal disease, adjuvant endocrine therapy is important, and particularly important if they're proceeding with breast conservation. But overall, I think that the findings from this study hopefully open the opportunity for more patients who have multiple ipsilateral breast cancer to consider breast conserving therapy as a reasonable option as they choose their breast cancer path. So that was kind of my one topic I wanted to talk about on breast surgery. Now I kind of want to switch gears and talk a little bit about all of the de-escalation we've done in terms of axillary lymph nodes. And really, before we go there, we just want to talk about the reason we want to de-escalate the extent of surgery for axillary lymph nodes is really that main impact on trying to decrease a risk of lymphedema. So we've all seen over our lifetime this evolution from the use of routine axillary lymph node dissection, which is a great operation, but has a significant lymphedema risk associated with it, to increasing use of sentinel lymph node surgery, allowing us to identify just 2 or 3 lymph nodes and resect those lymph nodes from the axilla, associated with a much lower lymphedema risk of around 6 to 8%. And this has been utilized now mainly for most patients with clinically node negative disease, but now also being considered for patients where we even have a positive sentinel node to avoid dissection. And then if we look at where the field is really going, I think it's exciting to see that there's going to be some patient populations where we can avoid axillary surgery altogether. There are ongoing studies to see, can we substitute axillary surgery with axillary ultrasound? And I think what I'm going to focus on is really identifying those patients that have such a low risk of having a positive lymph node that really we can forego axillary surgery, and identifying those patients where the identification of the axillary nodal positivity probably doesn't impact their management, and therefore we can also avoid axillary surgery. So the first topic for me is a no-brainer, but I think it's really important and interesting to mention, which is those patients with DCIS. So we know that DCIS is a non-invasive breast cancer, stage 0 disease. There are a lot of ongoing clinical trials really looking at, can we even forego surgery altogether in patients with DCIS and treat them with observation and with endocrine therapy. And the main goal of treatment of DCIS is prevention of development of invasive disease. So it's striking to notice that actually a lot of patients with DCIS are actually undergoing sentinel lymph node surgery. And the reason behind this is because of the concern that about 10 to 20% of the time when you excise DCIS, you may find invasive cancer at the time of excision. When we look at the NCCN guidelines says that for those patients having a lumpectomy, they should have a lumpectomy without lymph node surgery. And then for those patients having a mastectomy, they say with or without sentinel lymph node surgery. So what's happening in the US in the current day? We looked at the NCDB data, and this was from 2012 to 2017 at over 178,000 patients with pure DCIS treated with surgery. And we saw that axillary surgery was performed in about 38% of all of these patients. About 88% of those patients that underwent a mastectomy had a sentinel lymph node removed, and 19% of those patients that underwent breast conservation had axillary surgery performed. So really, how can we try to de-escalate our use of axillary surgery in patients with DCIS and really try to avoid the overtreatment of our patients with early stage or stage 0 breast cancer? This is a nomogram published from one of my colleagues looking at trying to identify the variables that predict for upstaging to invasive disease, because at the end of the day, that's really the question about why do you do a sentinel node? And so in this nomogram, you can put in the grade of the DCIS, whether there was a mass on ultrasound or mammogram, if there was more than one foci in the breast, and the largest linear extent of the calcifications mammographically. As you put this in, it will then calculate a risk of upstaging to invasive breast cancer. And so, for instance, in this situation with an intermediate DCIS, it was not a mass, it was a single focus, but it was a 2-centimeter area of calcifications. The risk of upstaging to invasive cancer was 6.6%, which is overall a pretty low risk. And this would be a patient I would significantly consider avoiding routine sentinel lymph node surgery in. One of the exciting things out there on the market, and I have not personally used this, but I'm very excited to see the data that's coming out on this, is the super paramagnetic iron oxide. This is a study from Europe looking at the use of SPIO injections. This is similar to your radioactive colloid tracer. It's injected into the breast or the subareolar region, and it drains to the lymph nodes, but it actually stays in the lymph nodes for about a month after the injection. And so this means that you can then do a delayed sentinel lymph node surgery and not automatically do sentinel node on all patients you operate on for DCIS. And of interest, this is also something to consider for patients undergoing prophylactic mastectomy. So in this study that was run out of Europe, they took patients with DCIS that they thought would be at a high risk of upstaging. So they limited the study to grade 3 or grade 2 disease that was more than 2 centimeters in size, or patients with a mass. They had the SPIO injected intraoperatively. They underwent their surgery without axillary surgery, and then they awaited the final pathology. And if they did upstage to invasive disease, patients were eligible to go back to the operating room for a second operation for sentinel lymph node surgery, with the goal really of avoiding sentinel node surgery for the vast majority of patients with DCIS. As I said, the study was conducted in a way to try to identify patients at high risk of upstaging. So they had about 25% of patients that were found to have invasive breast cancer. Out of those patients, 41 of the 47 were able to go back for sentinel lymph node surgery. And that enabled 78% of patients to actually avoid having any axillary surgery. They reoperated a median of 28 days after the initial surgery, so it gives plenty of time to get the pathology report and discuss with the patient. But overall, they saw a reduction in total cost of care by about 25%. So I think that's an interesting thing that's new on the market, and I think it's something that could be used for DCIS and also similarly, as I mentioned, potentially for patients undergoing prophylactic mastectomy, so that we can avoid always overtreating at the time of the breast surgery because we're worried that something may come back on the final pathology and then we wouldn't be able to go back again. So the second topic I want to talk about in areas where we can avoid axillary surgery, and again, now I'm a surgeon that's trying to encourage surgeons not to operate, but that I think it's all about trying to avoid overtreatment for patients. And this is women with age 70 and older with hormone receptor positive disease. And so the Society of Surgical Oncology's Choosing Wisely came out in 2016 and said, don't routinely use sentinel node surgery in clinically node negative women age 70 and older with hormone receptor positive invasive breast cancer. And it was subsequently updated in 2019 to limit it to hormone receptor positive HER2 negative breast cancer. So where did this guideline come from? What is the supporting data to support it? Well, in essence, for this patient population, we know that hormone therapy is going to be their standard of care. There's been data that we'll discuss that shows that axillary surgery itself doesn't have any impact on local regional recurrence or on breast cancer mortality. And therefore, for these patients age 70 and older that have hormone receptor positive, clinically node negative disease, we can reliably treat them without surgical staging of the axilla. This is some of the data that we've really supported this. The main study is the CALGB 9343 study, which we all know randomized patients between tamoxifen versus radiation and tamoxifen and showed the opportunity to de-escalate radiation. But importantly, when you look at the CALGB 9343 study, the vast majority of patients didn't have axillary surgery, and they showed excellent local control in the absence of axillary surgery. And then Martelli in Italy has done similar retrospective studies of large cohorts of almost 1,500 patients with 15-year follow-up. In that time period, actually comparing axillary dissection to no axillary dissection, and again, showing no difference in local regional control or overall survival. Now, when you look carefully at these studies, the vast majority of patients on both of these trials actually had clinical T1 disease. So that does become a question in my mind about how much this extrapolates to patients with larger tumors. So we went ahead and looked at the National Cancer Database to look at the data of what has been happening in the US at that time point in 2016, 2017. And interestingly, about 15% of patients in the National Cancer Database were not having axillary surgery performed. So we were already selecting some patients to avoid axillary surgery. And when you look at those that did have axillary surgery performed and you look at the likelihood of them being node positive, it's really not surprising to us to see that the patients that had larger tumors were more likely to be node positive, and patients with higher grade disease were more likely to be node positive. Taking these variables, we came up with a low risk criteria. This was patients that had grade 1 disease that was up to 2 centimeters in size, or grade 2 disease that was up to 1 centimeter in size. And this cohort actually had a low rate of nodal positivity of around about 8%. And importantly, it accounted for about 44% of all of these women over the age of 70 with hormone receptor positive disease. The flip side is the patients not meeting the low risk criteria, which I label the higher risk criteria. It's harder to remember that list on the right, but it's essentially those that have a tumor that's not grade 1 up to 2 centimeters and not grade 2 up to 1 centimeter. So larger tumors, higher grade. And that accounts for the remaining 54% of patients. But they have a threefold higher risk of nodal positivity, so about a 22% rate of nodal positivity in the high-risk group compared to the low-risk group. And so with this, how has this impacted my clinical management? This is what we now do at Mayo Clinic. If we see a woman who's 70 or older with hormone receptor positive breast cancer, if they meet that low-risk group, we routinely recommend omission of sentinel lymph node surgery, and that's if they're having breast conservation or mastectomy. If they do not meet that group, so they're in the slightly higher risk group, then I think it's a question of taking on a case-by-case basis. Look at the patient's comorbidities. How much over 70 are they? Are they 71? Are they 85? And would this patient consider chemotherapy if we were to identify positive nodes? You know, what is the impact of the axillary nodal surgery that we would have on the downstream adjuvant recommendations? As a result of this, you can see we implemented this reasonably well at our institution. You can see that our rates of sentinel lymph node surgery dramatically decreased from 2016 then to 2017 and 2018. You can see that we were most good at decreasing our use of sentinel node surgery in the low risk group. It was a much slower decrease in the patients in the higher risk group. And when you look at this by age, and I think this is interesting, although once you see it, it's not that surprising. Once patients get over the age of 80, we're much better at de-escalating than we are in the patients that are under in that kind of 70 to 80 range. And we were definitely better at de-escalating in the lower risk than we were in the higher risk. We looked at the impact on adjuvant radiation and adjuvant endocrine therapy because I think that's extremely important. And it's really good to see that the main driver of the use of adjuvant radiation, the use of adjuvant endocrine therapy was the patient's age. And that whether or not a sentinel lymph node surgery had been performed did not influence whether or not that patient received adjuvant radiation or adjuvant endocrine therapy. So just to summarize this portion of the talk, I would say for patients age 70 and older that have estrogen receptor positive disease, we really should be avoiding routine sentinel lymph node surgery. And this is not only for those with breast conservation, but also for those patients undergoing mastectomy. And so in my practice, if they have grade 1 disease up to 2 centimeters or grade 2 disease up to 1 centimeter, we do not do sentinel lymph node surgery. If they have larger tumors or higher grade disease, I consider it on a case-by-case basis, but I still lean towards trying to find a reason that I need to do a sentinel node biopsy, because the SSO Choosing Wisely guidelines really recommend against routinely doing it. So then for the last portion of my talk, and I do want to leave some time for some discussion, I also want to talk about how we can minimize the extent of axillary surgery. So if we identify that we are going to be doing sentinel lymph node surgery on patients, and we identify that a patient has a positive sentinel lymph node, do we always need to proceed on to an axillary lymph node dissection? So the next couple of slides, I think, will be kind of just recapping to everyone. I think everyone is well aware of the ACOSOG Z11 study, which was really a very practice-changing study, and particularly for surgeons, for us to identify patients that have 1 or 2 positive sentinel lymph nodes and then not go on to do an axillary dissection. So to recap, Z11 enrolled patients with clinical T1 or T2 disease that was clinically node negative. And we need to remember that when Z11 was designed, most centers were not using routine X-ray ultrasound. So this is clinically node negative disease in the era before widespread use of X-ray ultrasound. Patients that were treated with breast conservation surgery and planned whole breast radiation underwent their lumpectomy and sentinel lymph node surgery. And if they had 1 or 2 positive sentinel lymph nodes, they were randomized to axillary dissection or no axillary dissection. In the group that did have an axillary dissection, 27% of patients had a positive lymph node within the axillary lymph node dissection or additional positive lymph node. And with 10-year follow-up, we see no difference in local recurrence, axillary recurrence, local regional recurrence, survival, really no difference between the use of an axillary dissection or no axillary dissection in patients that what we call meet the Z11 criteria. I think this has been pretty widespread into practice now. Patients with a tumor that's less than 5 centimeters, clinically negative axilla, have a successful lumpectomy and have 1 or 2 positive nodes. If we know that patient will be having radiation and will likely be adherent to systemic therapy, we can forego axillary dissection. I think one of the areas that has caused a lot of discussion nationally is, what about if you do an axillary ultrasound and you identify a single lymph node in your FNA and it's positive? And a lot of people have a lot of concern that that leads to overtreatment of the axilla. And I would say it doesn't lead to overtreatment as long as you don't overreact to it. And so I definitely have patients, if they're planning to have upfront surgery and we're not going with a neoadjuvant approach, and it looks like they have a single abnormal lymph node by axillary ultrasound and it's positive, then I will give that patient the opportunity to be a Z11 candidate, proceed with sentinel lymph node surgery, making sure I do resect that lymph node that is positive. And at times I'll even have my radiologist put a clip in it and localize that lymph node for me, and then evaluate whether or not that patient has just 1 or 2 positive lymph nodes and therefore can be treated like Z11, or if that patient has 3 or more positive lymph nodes, in which case I would go on to an axillary dissection. And you can ask, what is the role then of the axillary ultrasound? But I think it does allow you to have a more nuanced discussion with the patient, because obviously they are going to be at a slightly higher risk of an axillary dissection. So you can talk to them a little bit more comprehensively in your consult about Z11. And if you think you would be likely to go on to an axillary dissection, you can also consider discussing with them about a lymphovenous bypass, etc. So what has been going on nationally in regards to Z11? This is some data we looked at from the National Cancer Database, looking at patients with breast conserving surgery. And I'm mainly showing this to you because we're going to go on and look at the same information for patients treated with a mastectomy next. But if you look at the 56,000 patients that would meet these criteria, 88% of patients are node negative. 11.4% or 6,500 also had 1 or 2 positive sentinel nodes, and only 0.6% had more than 2 positive sentinel nodes. If you look at this 6,500 with 1 or 2 positive sentinel nodes, 12.4% had an axillary lymph node dissection, and that rate was much higher. It was double in those patients that had 2 positive sentinel nodes, 20% had a dissection. Those with a single positive node, 10% had an axillary dissection. So we can see that surgeons are implementing this into their practice pretty well. The vast majority are not having a dissection, 12% are. And interestingly, when you look at the rate of positive nodes on that completion dissection, it's 29%, which is right in keeping with the 27% that we saw in C11. So nice reassuring data that this is being implemented into the practice. And so obviously NCCN is now completely adopted this, and they're recommending no further axillary surgery for those patients with micromets and those patients meeting the Z11 criteria. So present most of that really as background to, because really what I want to talk about is what about those patients that have exactly the same thing. They have 1 or 2 positive sentinel nodes, but that patient has elected to undergo a mastectomy rather than breast conserving surgery. And I think this is an area where this is hotly debated across many different societies, and we're lacking in a lot of guidelines for this patient population. So first of all, let's just have a look at what's happening across the country, looking at the National Cancer Database. Again, here you can see a slightly higher rate. About 20% of patients have 1 or 2 positive sentinel nodes. This is in the cohort that undergo a mastectomy. Of those that did have 1 or 2 positive sentinel nodes, we can see that about 46% of patients went on and had a completion dissection. So most surgeons are still proceeding with an axillary dissection in many of these patients. You can see again that it was more likely to have a dissection if you had 2 or more positive nodes, and only a little bit less likely with 1 positive lymph node. And the rate of additional positive nodes on axillary dissection is a little bit higher in this group, is 37% as opposed to 29% we saw in the patients with breast conserving surgery. Looking at how these patients that have 1 or 2 positive sentinel nodes that have a mastectomy are managed, we see that about a quarter had neither dissection nor radiation, 21% had a dissection only, 29% had radiation only, and 25% had a dissection and radiation. So overarching high level numbers looks like about a quarter, a quarter, a quarter, a quarter. But if we really delve this down based on the extent of nodal disease, it gets a little bit more interesting. And it's reassuring to see that those patients that have micrometastatic disease in their lymph nodes, vast majority are having neither dissection nor radiation. As you look through to those patients that had PN2 and 3 disease, most of those had dissection and radiation. And in that group with just PN1 disease, you can see it's kind of across the board here. And these are the guidelines that we've been working with at my institution. We really try to separate patients into low risk, intermediate risk, and high risk. So the low risk group, where I think we can not only avoid axillary dissection, but importantly also consider avoiding axillary radiation, is those patients that have small tumors less than 5 centimeters in size, and that have isolated tumor cells or micrometastatic disease in a single sentinel node. Then we get to this intermediate risk group, and I think this group is the group that is probably the most interesting, the most challenging, and of course the classic recommendation here is you really need to have true multidisciplinary input as you try to decide the best way to handle these patients. These are the patients where really we think that they should have some treatment to the axilla, be that an axillary dissection or radiation, but probably don't need to have both. And then the question is, which modality would be preferred for them? And so for these patients, often we would favor axillary lymph node dissection if this would enable that patient to avoid axillary radiation, especially those patients that have a reconstruction and those patients who otherwise don't have an indication for post-mastectomy radiation therapy. The flip side being those patients that already have an indication for post-mastectomy radiation therapy, such as a larger tumor size, more aggressive tumor biology, and those patients that are very worried about lymphedema, then we would recommend avoiding axillary dissection and then treating that patient with post-mastectomy radiation. So this is obviously a nuanced discussion. I think it's important that this is not made in a vacuum. This needs to be made considering the patient's preferences, considering the tumor size and biology, the radiation oncologist, and the surgeon's thoughts on this. I'm very lucky that we practice at an institution where I actually will call my radiation oncologist intraoperatively and discuss it with them. And not everybody has that level of support, but I think this is a very nuanced discussion. And then the third group is that high-risk group that need both the axillary dissection and the post-mastectomy radiation. We know that this group has the highest risk of lymphedema, but these are also the patients that have the most aggressive and highest stage tumors, so 3 or more lymph nodes, matted lymph nodes, gross extranodal extension. I think one of the most interesting things is when you look at the February 2022 NCCN guidelines, they actually amended their guidelines now to acknowledge that for patients who are treated with a mastectomy that have micrometastasis in the sentinel node, no further axillary surgery. And additionally, for those patients that have a mastectomy with clinical T1 to T2, clinically node negative disease with 1 or 2 positive sentinel nodes, if adjuvant radiation therapy is planned with intentional inclusion of the undissected axilla at risk, you can avoid axillary dissection. And so seeing this now implemented in the NCCN guidelines, I think will show us that hopefully we'll see further de-escalation in the use of axillary dissection in patients treated with mastectomy. And so I think that's going to be an exciting time as we move forward. So with that, I wanted to wrap up a little bit so we had some time for some discussion. Again, I'd really like to thank you for the opportunity to join your group today. Sorry I couldn't be there in person, but it's a huge honor to be part of the Nebraska Oncology Society this weekend.
All right. Well, thank you, Dr. Bowie. Do we have any questions from the audience? Can you hear her, Dr. Bowie?
Very, very faintly, but go for it. And if not, maybe we'll have you repeat it in the microphone.
Thank you. I really appreciate your talk. I agree that I think de-escalation of surgery is absolutely necessary. I have a couple questions for you. So you mentioned there's the 11 candidates that have a positive, one or two positive nodes before surgery, taking them for a sentinel node. Are you sending the remainder of those nodes for frozen section in the operating room and then making your decision for axillary dissection intraoperatively? Or are you waiting on final pathology?
At my institution, we freeze everything. So I am doing that intraoperatively. I think there's been a lot of literature around the country with different places approaching it differently. I mean, I think for patients where they have an FNA positive node and you want to make that decision about whether to proceed with a dissection or not, that's probably an area where it is valuable for your pathologist to freeze those nodes so you can try to do that all at one operation for the patient if possible.
Okay, I appreciate that. Thank you.
I thought you had a couple of questions. That was only one.
The mastectomy. So you do the same thing for your mastectomies. They're also frozen sections.
Okay.
I do. I freeze my nodes on my mastectomies too. I'll be honest with you. It's interesting because if I get a positive node during surgery, I often will go on to an axillary dissection. If I get a delayed positive node, meaning a positive node only on my final pathology, often then I'll have a more nuanced discussion with the patient, and then often the patient will go with radiation and will forego the dissection. Some of that is because the disease we find on final path that we miss on frozen section is smaller amounts of disease and we feel more comfortable not dissecting. Usually I think if it's a large enough metastasis that's identified intraoperatively, then I usually lean towards dissection. So I think it's, but I do think it's important. I would say 2-3 years ago, I was like, any positive node, definitely a dissection. Now I'm like, okay, let's stop. Let's reevaluate tumor size, tumor biology, number of nodes. And if you've only removed 2, I'll remove the third one just to see whether that one's negative, right? So it's nice to have it all at that time. And it's not bias, it's using all of the tools available to you at the time, right? And then I try to make that, decision intraoperatively. And, often I'll dissect, but sometimes I won't.
All right.
Oh, so sorry. So then in your clinically benign axillars, do you send those for frozen as well if they're not the 11 candidates?
Mayo freezes everything. Mayo's frozen section practice is they're very keen to freeze everything. So I definitely do freeze everything. But I think if you're in a practice where your pathologist, won't freeze everything and you need to be selective about what you freeze, then probably the Z11 FNA positive ones are high yield. These days with X-ray ultrasound and, selective MRI or routine MRI, depending on your practice setting, our instance of finding a significant positive sentinel node that we're surprised about is not that high, right? So, I think there's room to be selective. If you've got a small tumor, maybe don't freeze it. If you've got a larger tumor or lobular and you're more worried about, so I think you just have to adjust to your practice settings.
Thank you, I appreciate it.
All right, Dr. Bowie, we also have a question on the chat. Great discussion on an important topic. You had mentioned not overreacting in a clinically negative axillary ultrasound positive LN. Many patients are getting pre-op MRI. Would you also say the same for those MRI plus clinical LN negative patients?
Yeah, great question. Essentially, the short answer to that is yes. So what we do, we routinely get X-ray ultrasound on all patients. We're then selective with our MRI approach. But if I have a patient that then has abnormal appearing lymph nodes on an MRI, if their X-ray ultrasound was negative, I actually send them back for a second look X-ray ultrasound. Sometimes, the radiologist will look at it differently, and I will try to get an FNA of that node if possible. And then it's the same kind of thing. I mean, it's in my mind, it's like clinically positive, which is archaic, right? We know we're 50-50 in terms of how well we examine the axilla, meaning that if we feel a palpable node, 50% of the time it's going to be benign, 50% of the time it's going to be malignant. And then you've got imaging nodal disease, which is essentially either ultrasound or MRI, I would view as imaging positive. And for me, I use the imaging information as part of my clinical stage. So if the axillary ultrasound is concerning or the MRI is concerning and we do an FNA and it's positive, I'll label that patient as clinical N1.
Thank you, Dr. Gori. Maria, breast surgeon with the Met Center. Oh, sorry. So I know you didn't touch on this, but as we treat more neoadjuvant node-positive, clinical node-positive disease, and as we wait for the Alliance 0 or 211 about axillary de-escalation, which maybe you can hint or tell us when we potentially are gonna know any information in your practice. So I've been freezing and we've been freezing the node-positive treated has turned into clinically negative after neoadjuvant treatment. And a few times you get burned with a unclear freezing result. We don't know, there could be something there. I'm opting to not dissect those axilla intra-op and just waiting for final pathology. And I'm opting lately to just not send frozen period and wait for final pathology. Is there any circumstance with very minimal residual disease of the axilla, say an ITC, so YPT ITC or micromet? I'm being very hard pressed to have to dissect those patients. In your practice and at Mayo, are you dissecting those patients with very minimal residual disease? And then if you have any kind of advance on the Alliance 011-202.
Excellent question. So you brought me right to my passion, because I feel like I give that talk the whole time. But so in terms of any answers on 11-202, the bottom line is no. Unfortunately, with these cooperative group trials, while the statisticians know a lot, they truly blind the PI. So I really don't know anything more than you do, which I hate. I wish I had an idea, but I really don't. The only thing that I can say is that obviously the Data Safety Monitoring Board is watching the events on the patients of this trial every 6 months. And to this date, they have not closed us down. So at least that tells us there's not some major difference that they've seen at this time point between the two arms. And that's the only thing we can really infer. I will say that I kind of have two answers to that question. There's the textbook answer, and then there's what I do in my practice. And I'm happy to share both of those with you. My textbook answer is that in the absence of the data from Z11202, I do believe that the standard of care is that anyone that was node positive, treated with neoadjuvant chemotherapy and has residual disease post-neoadjuvant chemotherapy, the standard is still axillary dissection until we can prove that it's not. That's my textbook answer. And then as you talk about the isolated tumor cells, and this is an area where we really don't have much data, but when you look at the few papers that were published, if you look at the 1071 paper, the SNFNAC, and the data out of Sloan, patients that have isolated tumor cells post-neoadjuvant chemotherapy, about 30+% of the time had additional disease on axillary dissection. So it's a different patient population, I think, to those patients with upfront surgery. And we need to remember that this is residual disease that's chemo-resistant disease. And so it's probably more important that we try to handle it surgically. So textbook answer, I dissect everyone, including those with ITCs. Reality, very similar to my previous answer. I dissect them intraoperatively if I know they're positive intraoperatively. If I get it on a final path, then it's usually a nuanced discussion. And I'd say a lot of patients now are opting to go with definitive radiation and avoiding the dissection. And again, it tends to be those that have the isolated tumor cells or the micromets. I think if there's a significant volume of disease, I push a lot harder to go back and do the completion dissection. So I think, unfortunately, I think for right or for wrong, people, particular patients, and also partly surgeons and radiation oncologists and multidisciplinary teams are moving a little bit towards avoiding dissection and using radiation for selected patients with the small volume disease, exactly as you outlined. In terms of when will we know the results, the statistician wants like 7 years of follow-up. So I have this sneaky suspicion that by the time I present 11202, no one will care about it anymore because we'll already have voted with our feet and be changing what we're doing. But it's been a very thought-provoking study, I think, for everyone. It's opened up the idea of avoiding axillary dissection, and I look forward to having the definitive data to present. But yeah, it's not coming anytime soon. So in the meantime, I think we continue to use all of the tools that we have at our fingertips in terms of nomograms and, our own judgment, and go from there.
All right, Dr. Block.
Your patients who are 70 or older and meet the criteria that you presented to avoid axillary, sentinel node biopsy, I wonder if you have any leaning, depending upon the cell type, in particular lobular carcinoma, that seems to often have a negative ultrasound the axilla, but sometimes has positive nodes.
Yeah, lobulars are definitely very, very sneaky. And so I think they are a little bit harder to pick up with an X-ray ultrasound. One thing I didn't talk about a huge amount when I was talking about the age over 70 is that topic of X-ray ultrasound. I do like X-ray ultrasound. I have, as I mentioned, I use it on all of my patients with an invasive breast cancer. And to me, especially in this patient population where you're looking at omitting surgical staging of the axilla, it reassures me to have an X-ray ultrasound that was negative. It kind of reinforces my plan to omit X-ray staging for that patient population. I'm a little bit more leery for invasive lobulars. So I have a patient I saw yesterday. She has like a 1.9 or 2.1 centimeter invasive lobular, and I am going to do a sentinel lymph node surgery on her, but she's also 71, so she's just over the guideline. So yes, I kind of take histology in along with all of the other factors and make a nuanced decision.
Thank you.
Yes.
I just had a question. In regards to sentinel lymph node biopsy versus axillary node dissection, what would be the best recommendations on telling patients not to get needle sticks or blood pressures on a certain arm? Is there like a magic number of lymph nodes that, if you've had more than 3 lymph nodes removed, don't ever get a blood pressure in that arm or a needle stick?
That's a great question. I mean, historically, what I used to say is for an axe dissection, try to avoid that arm. For a sentinel node, I didn't really worry about it so much. The good thing is that most of our patients have 2 arms, so it's kind of like if you have a choice, go with the other arm. I will say most recently, not even recently, but over the last 5 to 10 years, there's increasing data really that the needle sticks and the blood pressure and that is very much a myth and doesn't seem to be that supported anymore in data. So I've actually eased up a lot on those restrictions. So definitely for sentinel node biopsy, I don't mind them having needle sticks on the ipsilateral arm. I think really as a field, they're moving away from kind of having those patients protect that arm quite as much as what we did kind of 10, 15 years ago. So I usually say, well, if you've got 2 arms and it's just as easy to take it from the other arm, use the other arm, but I'm not as fixated on the guidelines as what I used to be 5 to 10 years ago, because I think the data really supports we were probably causing more anxiety for our patients, asking them to protect that arm, and that the data really wasn't robust enough to support it.
Thank you. I agree. I get patients that come in and they're terrified to ever use that arm ever again, even if they've only had 1 sentinel lymph node.
Yeah, I think we're instilling more fear than doing more harm than good with that one. So I think with sentinel node, it's probably fine to use the arm. And it's probably fine to use the arm with the dissection, but it's hard to switch that old surgical dogma.
Thank you.
Do we have any additional questions? All right, seeing none from our live group or from the chat box. Thank you so much, Dr. Bowie.
I really appreciate it. Thanks so much for including me in your meeting.
All right, well, we look forward to hopefully hosting you in Nebraska at some point. All right. Well, thank you, everyone. We'll move on to our next speaker,